Good morning, everyone. Today we'll be discussing chiari malformations, specifically types I and 0. By the end of this presentation, you should understand the anatomy of these conditions, be able to identify the classic presenting symptoms through taking a thorough patient history, and know the appropriate imaging required to confirm the diagnosis. To begin, let's review some background on the history of chiari malformations. This anomaly was first defined in 1891 by the Austrian pathologist Hans Chiari through his postmortem examinations. He described the abnormality where the cerebellum protrudes through the foramen magnum, though his mentor Julius Arnold also contributed to characterizing this condition that now bears both of their names. Chiari malformation type I, often referred to as the adult type, is the leading cause of syringomyelia and occurs with osseous abnormalities at the craniovertebral junction. In contrast to types 2 and 3, type I typically presents in the second or third decade of life, though more recent reports suggest there may be two peak ages around 8 to 9 years old and 41 to 46 years old for unknown reasons. There is evidence that chronic tonsillar herniation in chiari malformation type I could be attributable to underdevelopment of the occipital bone and overcrowding of the cerebellum within a too small posterior cranial fossa. Importantly, this is not a malformation of the foramen magnum itself. In a landmark study by Murat et al. Of 364 symptomatic chiari patients, the mean age of symptom onset was 35.9 years. Interestingly, 24% of patients cited trauma as the precipitating factor. However, the majority described a spontaneous onset of symptoms, with 37% reporting lifelong issues like headaches and clumsiness. Does the fact that 24% cited trauma as the precipitating factor mean the trauma caused the chiari malformation? This is unlikely, as the malformation is thought to be congenital. More plausibly, the trauma may have accentuated pre-existing tonsillar impaction or destabilized CSF flow dynamics in these patients. The symptoms of chiari malformation type I can fluctuate between periods of exacerbation and remission. The most common symptom experienced by 81% of Murat's patients was a suboccipital headache, a heavy, crushing, pressure-like sensation radiating to the vertex, behind the eyes, neck and shoulders. A distinctive feature was that these headaches tended to be accentuated by Valsalva maneuvers, physical exertion, head dependency, and sudden changes in posture. Female patients of menstrual age often experienced worsening around their periods. With few exceptions, these headaches could be distinguished from cervicogenic or other headache types. Ocular disturbances were reported by 78% of patients and included retroorbital pressure or pain, visual phenomena like floaters or flashing lights, blurred vision, photophobia, diplopia, and visual field cuts. Notably, while these symptoms worsened with the same factors as the headaches, optometrist and ophthalmologist exams were typically normal. In fact, ocular disturbances among young women were the leading cause of an erroneous diagnosis of multiple sclerosis in this cohort. 74% of patients also experienced otoneurological issues like dizziness, disequilibrium, ear pressure, tinnitus, and hearing changes, again exacerbated by the same factors. Diving deeper into the otoneurological symptoms, 81% reported oral fullness and tinnitus along with headaches, 69% vertigo, and 56% oscillopsia in one study. These distressing symptoms highlight the importance of taking a careful patient history. Moving on, 52% of Murat's patients had lower cranial nerve, brain stem and cerebellar disturbances. The most common were dysphagia or difficulty swallowing, sleep apnea, dysarthria or slurred speech, tremors, palpitations, and poor coordination. Sleep disorders in particular have been attributed to hydrocephalus, which can occur with more severe obstructions of CSF circulation seen in chiari malformation. Disturbances of spinal cord function were present in 94% of patients with an associated syrinx. But an unexpected finding was that 66% of patients without syrinx still had similar, though less severe, symptoms like muscular weakness, numbness, non-radicular pain, and spasticity. Other objective findings in this non-syrinx group included impaired hand dexterity in 48 patients, muscular weakness in 25, sensory disturbances in 18, and hyperreflexia in 18. These neural abnormalities were still attributable to the secondary effects of chronic tonsillar herniation. Rounding out the list of symptoms, over half of Murat's patients experienced nonspecific issues like chronic fatigue, memory impairment, cervicalgia, low back pain, and episodic nausea or vomiting. Tragically, 59% had previously been dismissed by at least one physician as having a psychogenic disorder before their chiari diagnosis. This sobering statistic underscores how patients can suffer due to doctors not listening carefully, lacking knowledge about uncommon conditions, having bias, and simply not thinking through differential diagnoses thoroughly. As Aldous Huxley famously said, facts do not cease to exist because they are ignored. Moving to epidemiology, as more patients undergo brain and spine imaging, the estimated occurrence of Chiari malformations has been revised upward to 1 to 4% in recent years. This highlights how crucial it is for clinicians to maintain a high index of suspicion. Synthesizing the key historical questions to ask, you'll want to probe for headaches, noting location, relation to position and exertion, as well as ocular issues like retroorbital pain or visual disturbances despite normal eye exams. Otoneurologic symptoms like tinnitus, vertigo, and hyperacusis are also red flags, along with any reports of fatigue. If you elicit several of these symptoms in a patient, it should prompt you to pursue further detailed questions and appropriate imaging. Doing so can reduce considerable patient suffering that often occurs for years due to lack of diagnosis by previous clinicians who did not listen, believe, or know to look for it. Epidemiologically, Chiari malformation type I is considered a rare disorder with limited data, though it disproportionately affects females. 25% of patients do cite antecedent trauma like whiplash injuries or head/neck blows as a potential predisposing factor. These traumatic mechanisms may accentuate tonsillar impaction or result in subarachnoid hemorrhage that destabilizes CSF dynamics. Current evidence also suggests that eliciting the characteristic symptom profile on history is highly accurate for diagnosing this condition. The current understanding is that syrinx formation results from obstructed CSF flow at the foramen magnum, which exaggerates the systolic pulse wave and drives CSF into the spinal cord central canal through paravascular spaces. More severe obstruction can also cause hydrocephalus. In one study of 22 Chiari patients, the most common symptoms included headache at 73%, neck pain at 41%, dysphagia and gag reflex impairment at 50% each, extremity numbness/paresthesias at 55%, dizziness at 59%, and 41% had both retroorbital pain and tinnitus. Importantly, the cerebellar tonsils can obstruct CSF flow at the foramen magnum without necessarily meeting the 3 to 5 mm herniation criteria for a classic Chiari type I malformation. This is referred to as a Chiari type 0 malformation, first identified in 1998. Multiple studies have found that posterior fossa size tends to be smaller in both Chiari types 1 and 0 compared to normal. This suggests that posterior fossa crowding may be more clinically relevant than simply measuring the degree of tonsillar herniation, which does not always correlate well with symptoms. In fact, one study found over 14% of asymptomatic patients had tonsillar descent of 5 mm or more. In the Chiari type 0 variant, patients typically develop a syrinx formation despite less than 5 mm of cerebellar tonsillar herniation. Decompressing the foramen magnum surgically has been shown to improve symptoms and reduce the syrinx in these cases, similar to management for type 1 malformations. While Chiari type 0 remains a somewhat rare and controversial entity, the underlying concept of posterior fossa crowding being associated with both types 1 and 0 is gaining traction. Posterior fossa volume and crowdedness may be better predictors of symptomatology than rigid tonsillar herniation criteria. As such, posterior fossa crowding is increasingly used interchangeably with or preferred over the term Chiari malformation type 0 by some experts to describe this pathology more accurately with less debate. An important associated finding is that Chiari type 1 patients with a normal appearing posterior fossa may have an accompanying tethered spinal cord. One study found tethered cords in 14% of classic Chiari 1 cases and 63% of cases with low-lying cerebellar tonsils. In terms of diagnostic imaging findings, the most constant features on MRI are compression of the CSF spaces posterior and lateral to the cerebellum, seen in 100% of cases, as well as tonsillar herniation of at least 5 mm, present in 91% of the Murat cohort. It's crucial to recognize that you cannot definitively make the diagnosis of a Chiari malformation from cervical spine MRI alone, as the critical images of the foramen magnum are not included. To properly evaluate, you must order dedicated brain MRI imaging, potentially within Mr. CSF flow study as well if available. Regarding management, some Chiari malformation patients may spontaneously improve over time or with maneuvers like the chin tuck, though I have not personally seen this be effective. Cervical traction is generally not an advisable approach. For patients who do not respond conservatively, surgical decompression by widening the foramen magnum to reduce tonsillar impaction is the definitive treatment. Historically, the decision for surgery was based primarily on the degree of tonsillar herniation and symptom severity. However, more recent evidence suggests that directly evaluating CSF flow obstruction at the foramen may be a better determinant of who requires surgical intervention and predictor of postoperative outcomes compared to just tonsillar descent measurements. Looking ahead, you will inevitably encounter chiari malformations, myelopathy, and cervical instability in your clinical practice, regardless of what any practice-building courses might claim. The only way to find pathology is to actively look for it through careful history taking and examination. Illustrating this point, in just the limited context of this course, we identified 11 students, 1 patient seen in our clinic, and 1 intern's mother who had an undiagnosed chiari malformation type 1. You will miss what you don't actively seek. While not a core symptom, there have been occasional reports of seizures occurring in chiari malformation patients, both asymptomatic cases and those requiring decompression surgery. The course of epilepsy tends to be relatively favorable when present. In a subset of pediatric chiari cases, seizures can manifest as part of a broader neurodevelopmental disorder also involving intellectual disability, autism, and dysmorphisms, likely related to shared embryological mechanisms with chiari 2 and 3 malformations. However, for the adult-type chiari 1 malformation that we've focused on today, seizures are quite rare. Any new-onset seizure warrants an urgent, broad workup to evaluate for pathology rather than assuming a chiari malformation is the underlying cause. In conclusion, chiari malformations, while uncommon, have a fairly recognizable constellation of symptoms that you must be aware of in order to make the diagnosis. Careful history taking is key, along with maintaining a high index of suspicion. Failure to identify these cases can subject patients to years of suffering and inappropriate labeling. Armed with the knowledge we've covered today, I'm confident you'll be able to properly evaluate patients for chiari malformations going forward. Proactively seek the facts through thorough examination rather than ignoring potential red flags. Thank you all for your attention, and I'll take any remaining questions at this time.